Good evening, Dr. Pritam. Can you hear me?
Yes.
Okay. Just a second. Yeah, Dr. Pritam, can you say something?
Hello, sir.
Hello, hello.
Hello. Uh,
Yeah, it's not connecting to my earpiece. It's using the computer speaker.
okay.
How can I address this? Okay, let me see. Yeah, Indrani, can you speak?
Yes, sir. Can you hear me now?
Yeah, I can hear you from my computer speaker, but not yet into my ear. But am I loud and clear?
Yes, sir. You're audible.
Okay, okay, okay then.
So good evening to all of you. We'll start the meeting in another 2 minutes. Indranil, kindly see whether the national president and national office bearers have joined.
Yes, sir.
Anil sir is there. Yes, Dilip sir and Anil sir are there at IMA headquarters. Yes. So Indranil, I think we can start the meeting.
Sure, sir.
Dilip sir, shall we start? Dilip sir, shall we start the meeting? Are we audible at the headquarters? I can see Dilip sir and Anil sir, but it is muted there. Shall we start? Yeah.
Go ahead.
Yeah, please. Indranil, please start.
Yeah. Thank you, sir. A very good evening and a very warm welcome to one and all present here. I am Dr. Indranil Deshmukh, National Secretary of IMA Junior Doctors Network. It is my great pleasure to welcome you all to this National Online CME organized by IMA Headquarter and IMA JDN on the occasion of World Malaria Day 2025. We are truly thankful for this overwhelming response to this CME. The Zoom session has a capacity of 500 participants, and I'm happy to share that it is nearly full. And we are also sharing the YouTube link on our WhatsApp channel for the remaining participants. So let us now begin the inaugural ceremony. To begin this session with blessings and sense of purpose, I invite Dr. Shravan Dave, Finance Secretary of IMA JDN, to lead us in the IMA prayer. Over to you, Dr. Shravan.
Good evening, everyone. Respected Anil sir, Dilip Bhanusali sir, and Srijit sir. I request everyone to repeat the IMA prayer. May everybody be happy.
May everybody be happy.
May everybody be healthy.
May everybody be healthy.
May everybody be free from pain.
May
May
everybody
everybody be free from pain.
May everybody be free from sorrow.
May everybody be free from sorrow.
May we be the healing cure
May we
May
be
we be the healing cure
beyond every greed and lure.
beyond every grief and lure.
Thank you. Over to you, Dr. Indranil.
Thank you, Shravan sir. Now I will be leading the physician's prayer. I will request not to repeat. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skills to my hands, clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose, strength to life at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. Thank you. Now I request Dr. Shabrinath, the Director of Cultural Affairs, to lead us in the flag salutation.
Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the committee of nation. Jai Hind. Jai.
Okay.
Thank you, Sabri sir. To officially welcome us all and set the tone for the evening, I now invite Dr. Karan Juneja, convener of IMA JDN, to deliver the welcome address. Over to you, Karan.
Thank you so much, Chandral bhai, for the opportunity. A very good evening to all the respected leaders and all the participants who have joined the session, important session today. I welcome our National President, Dr. Dilip Bhanushali sir, who, despite his very busy schedule, has joined us directly from the IMA headquarters, along with our National President-elect, Dr. Anil Naik sir, our Honorary Secretary General, Madam Dr. Dr. Sharbari Datta Madam, our President, immediate past President, Dr. R.V. Ashokan Sir, who is always there to motivate us and energize us. And yes, again, tomorrow we have another session coming up by Commonwealth Medical Association on TB elimination. We are already preparing for it. I'll just post this session and we hope to see all of you even there tomorrow. And yes, it's a great honor to see such a huge gathering. We are already reaching 500 and numbers are just increasing and increasing, and we are reaching about 500. After that, all those who are not even able to join, we'll be sharing the YouTube link with all of you. And I thank Dr. Srijit and Kumar sir for taking the lead and initiative for getting this session done, and Indranil Deshmukh for executing it with full dedication and full zeal. Dr. Piyush Jain sir, our honorary finance secretary, for allowing us for a Zoom link of 500 and always being there with us for the session. And yes, all our senior leaders and our young brigade of Indian Medical Association ready to combat against this deadly disease, malaria. And this for the session, Dr. Anirban Dalai sir, our past vice chairman, and the person who led this initiative to have a collaboration with JIMA, Journal of Indian Medical Association, a very important vertical for which our young doctors can collaborate and send their research articles. They can send their papers, they can get it published, and it is a good opportunity for all our young doctors, which they can avail via lifetime membership of Indian Medical Association, or if up to 35 years of age, they are not able to afford, they can join via IMA JDN link online available on the website. We welcome you all for the session and best wishes. Thank you so much. Over to Indra. Thank you.
Thank you, Karan. Now it gives me a great pleasure to invite the leader of young team, Dr. Srijit Kumar sir, who is the national chairman of IMA JDN. I will request sir to share his introductory remarks. Over to you, sir.
Yeah. Thank you very much, Indranil. Respected National President Dilip Bhanushali sir, respected National President-elect Dr. Anil Naik sir, immediate past President Dr. R.V. Ashokan sir, Sarbari Datta Madam, our Honorary Secretary General, distinguished senior leaders of IMA, and my dear friends in JDN. Of course, I can see the figure touching 500, so nobody should get disappointed. The others can always watch on YouTube and also post your questions there. First of all, I express my sincere gratitude to our headquarters. The duo of Dilip sir and Anil sir had been there right from the beginning, and I've flooded them with many requests every day. And the only answer, which I know even before I ask the question, is yes. And such dedicated leaders and such affirmative leaders, such positive leaders, and we have had a tremendous run with both of you. And just 2 days back, as we are all aware, Junior Doctors Network were given with the blessings by the national headquarters. They personally tied up the appointment with the DGHS, and we could present all the views of all the young doctors of the country to the national to the Union Ministry and the Health Department. So we are extremely thankful to the headquarters for facilitating and helping and supporting the young doctors of the country. And we pledge that we will carry out the vision of our national president, Dilip sir, and our national president-elect, Dr. Anil Naik sir. We're also thankful to Sarbari Madam. She gives up all administrative support. And of course, Ashokan sir is always our guide and mentor. Now, today's theme is very important. It's the World Malaria Day. Now, I come from a state where, malaria is very scanty. In fact, during my MBBS days, I have never seen a malaria. But thereafter, I joined the army, and then I knew what malaria means to India. And in army, it is said that any fever, unless proven otherwise, it's malaria. And during my stint, I could see all sorts of complications of malaria, and I was bewildered. And back home, back in Kerala, again, Kerala has some pockets of malaria, but somehow malaria escapes Kerala, or Kerala escapes malaria. But that's not the situation nationwide. Of course, the numbers are decreasing, but still we have millions of cases countrywide, worldwide. We have more than 60% of share of malaria cases in Southeast Asia. And aptly, the theme of Zero Malaria Starts With Me is coined for this year. And JDN has taken that responsibility to let every doctor and every citizen know that, yes, the mission starts with us. We have some of the cream faculty of the country. And I have our dedicated leader, Dr. Anirban, who coined the idea and is coining today's program and moderating today's program. So I'm extremely grateful to the malaria control team of the World Health Organization and also the important leaders from malaria sector who have joined today. Our young doctors, Dr. Indranil, Karan, and all the young team who have elegantly organized this. And the headquarters, once again, thank you so much for helping us arrange this meeting. Over to you, Indranil.
Thank you, Srijit sir, for your motivating words and the constant encouragement. Now, it is my privilege to invite our esteemed National President of Indian Medical Association, Dr. Dilip Bhanushali sir, who is known for his visionary leadership, for his calm leadership, and who is always very supportive and very accessible to even to the young doctors. I will request sir to give his inaugural address, to deliver his inaugural address. Over to you, sir.
Yeah, namaskar. Good evening. I bring warm greetings from headquarters with my colleague Dr. Anil Nayak, rest of the office bearers from headquarters. Of course, Dr. R.V. Ashokan, as Dr. Sujit has rightly said, our motivator and leader, Dr. R.V. Ashokan. Sujit Kumar, who has been the forefront of JDN, is a sparkling face of JDN. Dr. Indranil, Dr. Ahuja, and all the office bearers of JDN. Well, you people have been doing a wonderful job. I see that this is what you have been doing all these months since this has been formulated. Day out, you are after that, and it's good to see that young blood is doing wonderful job in JDN. Well, this topic of malaria, as you rightly said, we have been seeing as a family physician has to see a lot of malaria cases earlier. But last 4-5 years, especially after COVID, we have hardly seen any malaria case. But that doesn't mean malaria has gone off. Malaria is there in subcontinent countries, and in fact, the treatment part of malaria also has changed drastically. So this webinar, I'm going to, and this webinar is going to throw light on this, and our eminent speakers who are there will definitely guide us and tell us what has been happening on that front. I once again congratulate all of you for being there and the overwhelming response for this webinar. That shows the zeal that JDN has pumped in this era of a new leadership under Dr. Kumar. So let me wish you all the best, and let's start the program. Thank you.
Thank you very much, sir, for your powerful words and your inspiring presence. Your leadership continues to guide and energize us all. And we are glad to share that JDN was a part of the recent meeting with Director General of Health Services to discuss the updates on the Residency Scheme 1992. And this was made possible because of the efforts taken by our National President, sir, and his whole team, whose initiative helped to secure the invitation and ensure that JDN could actively participate and share the valuable inputs in the review meeting. So thank you, sir. We are now honored to hear.
Last minute effort that we wrote to them that JDN should be included, and I'm thankful to them that they included.
Thank you for your efforts, sir. We are now honored to hear from some of the most respected leaders of the Indian Medical Association, leaders who have shaped and strengthened the path we walked on today. I invite Dr. R.V. Ashokan, sir, the immediate past president of IMA. Sir is a very respected leader who has always stood up for the doctor's right and spoken with a great clarity and conviction. I will request sir to address the gathering. Over to you, sir.
Thank you. Thank you. Respected and beloved National President Dr. Dilip Bhanushali, my beloved Secretary General, as well as today's National President-elect Anil Kumar J. Nayak, and my very dear friend, colleague, Dr. Srijit N. Kumar, Honorary Secretary General Dr. Sarbari Datta, and the faculty of today, Dr. Danu Jain and Dr. Badri Papa. And of course, the man from Jima and the original man from JDN, Dr. Anirban Davlati, Dr. Pratham Roy, and the young team, Dr. Karan, Indranil, Goni, Sabari, and everybody. And I feel very young when I join all of you because the power that you bring is something unique. It actually strengthens Indian Medical Association. It's the effort of our national president to see that JDN was represented in the DGHS meeting where the residency scheme was being discussed. And I also congratulate you that in a very short time you were able to very precisely, briefly, precisely, very comprehensively, you could put up all the points that were necessary. Whoever did that, I perhaps think that it's a collective effort, but you did a good job. You did a good job of representing yourselves and be seen there as JDN. Perhaps the only organization which was an all India in nature. And JDN for the past 10 years, it has come of age. There is a difference when we look at the young doctors through the prism of JDN as well as Emerson. The JDN are actually doctors, and Emerson are still medical students. To that extent, there is a difference in perspective, attitude, and even behavior. And the etiquette of JDN has to be distinctly different. And perhaps it should be vibrating in a way that it empowers the entire Indian Medical Association. Actually, right now, the path is correct. Instead of speaking only about our demands, JDN is there in tuberculosis, is there in malaria, and it's there in the antibiotic microbial resistance also. So I think these are very professional issues as well as the important public health issues of the country. There were times during our independence when the chloroquine or even, those days, quinolone was called as quina. It was sold in post offices. If somebody had a fever, it was distributed free of cost. This is history of malaria. Many of you would have know that Ronald Ross detected it in India because it's a product of modern medicine in India. Modern medicine has a history and legacy in India. So I'm happy that you are all, working very closely on the public health issues. And I can also see many of the public health, consultants today are from JDN, even in the government of India. So I'm really proud that you have all come of age. You are able to hold on yourself, and you are able to work on not only on professional issues, you are able to serve your own issues, and also look at what you can contribute to the public health. So all the best, JDN. Go ahead in the same speed throughout the year. Congratulations. Thank you.
Thank you, Ashokan sir, for your thoughtful message and for always supporting the younger generation. Thank you. Next, I invite Dr. Anil Kumar Nayak sir, President-elect of IMA. Sir is known for his calm and forward-looking leadership. His inclusive approach is admired across the organization. I will request sir to address the session.
Thank you, Dr. Indranil. Dr. Dilip Bhanusali sir, President, Dr. Ashokan sir, Dr. Srijit, Dr. Sarvari Dattaji, Juneja, and all the office bearer of the JDN and all the members who have joined this seminar. As you know, today is the World Malaria Day. And when you look into the history, previously it was celebrated from 2001 on 25th April as a World African Malaria Day. Then in 2007, it was started on 25th April. They are celebrated as a World Malaria Day. As you know, our government and when we studied in prevention and social medicine during our undergraduate course,
we are trying to eradicate malaria from India, but still we are waiting. And as you know, it is a vector-borne disease, so we can prevent vector-borne diseases. And because of this Plasmodium uh, protozoa, with P. falciparum or P. vivax, we can do prevention. So prevention and this time on what we have to do on this 25th April, raise the awareness among the community. Clean water, everything we can prevent, how to prevent. So awareness is more important. Promote prevention to mobilize the community action. Because where there is a water storage, there will be a Anopheles mosquitoes there and they will do the malaria. So prevention is better than cure. So we have to mobilize the people to make cleanliness, Swachhata Bharat, Swachh Bharat Abhiyan, that is a most appropriate call. So prevention for education is there. So on that we have to mobilize the people, educate them regarding the malaria. And regard to 2025, the theme, every year there is a theme regarding the World Malaria Day. This time theme is malaria ends with us. Malaria ends with us. Reinvestigate, reimagine, and reignite. This is the thing. So we have to spread this message and spread this theme to all over the country by doing social service. We have to also educate the people through our Aao Gam Chale project, on which we are adopting slum area and villages. So we can, by education, we can prevent the disease. Regarding the JDN, I congratulate all the committee of the JDN new committee, but as we have done a membership drive during February to April, so I also recommend new junior doctors have joined in their post-graduation part. So we can give a 25% discount from your fee, and each and every college we have to, our members to go and increase the membership drive, because Bharatiya Janata Party is ruling in 30 years on the country, although they are doing membership drive. Why should we not? And we have, I am congratulating Dr. Bhanusali, this membership in 1.5 years, we are able to enter more than 8,000 new members in our IM headquarters. So our strength is now 3.94 lakhs. So we can increase our strength by membership drive. So I request all the office bearers, Dr. Sijit, Dr. Karan, Dr. Indranil, and all the office bearers to do each and every medical. There are 700 medical colleges. Each and every medical college have a JDN network. So we can spread the message easily. Whenever there is a problem of the students or residents, we can mobilize them. So we have all the data of the medical junior doctors, and we can enroll more and more member from each and every country, each and every state and Indian territory. That is my request to each and every medical college have our body. We should also make a flex banner, join GDN, join MSN, and we can strengthen our, because canvassing, and we have to work like a professional, by like a corporate organization, and by doing such type of drive, we can increase our membership, and by increasing our membership, our strength become powerful, and government will not hold any meeting without consulting you. That is my promise to you. If your strength is more, government have to come to you before taking any decision. So strength is important and unity is important. So I request you all, kindly take 1 month or 2 months for membership drive, visit many colleges, contact with the junior doctors, and we can solve their problem by our strength. So that is my request. You should try to increase membership. That is my request. Thank you for inviting me, and allow me to say a few words to all the delegates. I congratulate more than 500 people have already joined. So I congratulate all of you for this seminar, on World Malaria Day. Thank you very much. Thank you very much.
Well, thank you very much, Indranil. Just give me 1 minute. Now, let me please respond to Anil sir, who has put up probably the most important point, and not just for IMA, but also for the JDN. So right now, sir, in another week or so, we are trying to constitute the National Council, and thereafter, our agenda will be membership drive. And all those who are present here would realize that if we have to get our rights, if we have to get all these CMEs going on, we have to be a huge gang, and we will definitely ensure that in the next 2 to 3 months, JDN will at least quadruple, and we will try our level best, sir. Thank you so much for that very kind advice. Over to you, Nindra.
Thank you, Nayak sir, for your inspiring words. We look forward to your continued guidance and leadership in the coming term. I would also like to acknowledge the presence of senior IMA leaders in the meeting. Our past HSG, Lele sir, Datta sir is here, Chairman of MSN, Dr. Shivkumar Utture sir, Abul sir, and thank you for joining and blessing this session. To conclude this memorable inaugural session, I now invite Dr. Nagamba Akham, the Director of Events and Workshop, to deliver the vote of thanks.
Is Sir Varimadan there, or Madam couldn't join?
No, sir.
No issues. No issues. Okay.
Okay, thank you, Dr. Indranil. A very good evening once again to esteemed dignitaries, seniors, and dear colleagues. I extend my heartfelt gratitude to everyone who contributed to the success of today's inaugural program. I would like to begin with a profound appreciation for Dr. Shravan Dev for delivering the inspiring IMA prayer, setting a solemn tone for our gathering. Also, our sincere thanks to Dr. Indranil Deshmukh for the meaningful physician's prayer, reminding us of our noble calling. I would also like to extend our gratitude to Dr. Sarvari Nath for leading the flag salutation with the utmost reverence, instilling a sense of pride and unity amongst us. A special note of thanks to Dr. Karan Juneja for the warm and engaging welcome address, which set the stage for this memorable event. We are deeply appreciative of Dr. Srijit N. Kumar, Sir, Chairman of the JDN, Sir, for your insightful introductory remarks, providing us a very clear vision for our proceedings. And also, I would like to extend a heartfelt gratitude to Dr. Dilip Bhanusali, Sir, the President of the IMA, for delivering a thought-provoking inaugural address that inspired all of us. We are also immensely thankful to Dr. R.V. Ashokan, Sir, Dr. Anil Naik, Sir, for their enlightening addresses, which not only enrich our understanding, but also motivating us to strive for excellence in our profession. I extend my thanks to all the organizers, volunteers, and support staff who work tirelessly behind the scenes to ensure the seamless execution of today's inaugural function. Your dedication is truly commendable, and thank you. And now I would like to hand over to Dr. Indranil for the continuation of the academic session. Thank you.
Thank you, Dr. Nagamba. And now we move on to the most awaited part of today's program, the main academic CME session. I am pleased to hand over the session to our moderators, Dr. Preetham Roy, who is the NTD coordinator at World Health Organization, and Dr. Anirban Dalui, sir, who is the honorary assistant secretary at GIMA, also the advisor to the JDN team, who will now take us forward with the expert discussions and a presentation. Over to you, Preetham sir and Anirban sir.
Thank you so much. Thank you so much, Indranil, for giving us the opportunity. So on this Malaria Day, I would like to thank our respected national president, our immediate past national president, our national president-elect, our HSG madam, for giving us this opportunity to host this webinar. And I must be thankful to the chairman of IMA JDN, Dr. Srijit N. Kumar sir, who has always been guiding us. So for giving us the platform, giving us the whole details, and to make this platform open to all the junior doctors and the doctors, members of IMA and the leaders of IMA. I must be thankful to all of them. I must be thankful to Dr. Pritam Rai, who has actually coined this idea along with me, and he has made some communication with our respected speakers. Actually, we are honored to have both of them. Dr. Pritam Rai will give the brief idea and the brief introduction of all of them, but they need no introduction. Just in summary, I may say that World Malaria Day, it is observed every year on 25th April with a good amount of decline in malaria cases from, if we consider from 2023 to 25. India already exited the WHO's high burden to high impact group in 2024. So the claps must go on, and all credit goes to our National Vector-Borne Disease Control Program team. And I must echo the words of our Prime Minister also. He said that malaria has been a big challenge confronting humanity for 4,000 years, and even at the time of independence, it was one of our biggest health challenges. Today, I can say with satisfaction that the countrymen have collectively strongly fought this challenge. So, our national president, under the leadership of our national president and all respected leaders, IMA being the largest body of doctors of modern medicine, we are privileged to have this webinar, and for further scientific talk, I request Dr. Pritam Rai to carry forward and to invite the speakers one by one. Thank you.
Thank you. Dear colleagues, I think on this World Malaria Day, I wish to acknowledge and thank Indian Medical Association, which is the largest medical professional association, for the kind allowance to have this special webinar on malaria and celebrate the outstanding progress that India has made towards malaria elimination, a journey which is marked by resilience, innovation, and a steadfast commitment to public health. In this occasion, we have with us Dr. Badri Thapa, who is the team lead of the Communicable Diseases India WHO Country Office. And he also has a vast experience of malaria elimination in Southeast Asia. So on a global perspective and also from a Southeast perspective, and then his vision for what India can do for hastening the innovation to reduce the malaria burden. So he will be speaking about the WHO strategies and the regional progress for us. So over to you, sir, for your deliberation.
Yeah, am I visible, Dr. Pritam? Yeah, am I visible?
You are visible, sir. Your slides are not visible, but you are visible.
Okay, let me spend 1 or 2 minutes before I show my slide. Is that okay?
Sure.
Yeah, I think I need to thank to the IMA for giving this opportunity. I especially thank Dr. Pritam and Dr. Anirban, for coordinating this event and inviting me and bringing me to this event to share my experiences, as Pritam mentioned, in the Southeast Asia region. And as you know, that today is the World Malaria Day, as has been mentioned by many distinguished colleagues. So in this very day, I urge our medical fraternity, whether it is a clinician, whether it is a public health physician, to reinvest, reimagine, and reignite to end malaria together in India. And as Dr. Anil mentioned, that there are 700 medical colleges in India. So if you add up number of medical doctors, number of nursing staff, number of other assistants that are working for health, though that adds significantly to the number that can contribute to this malaria endgame. And today also, I would like to congratulate Dr. Tanu Jain, who would be here, who will be here in a short time. She had organized a day-long event today to mark this the World Malaria Day. And I would also like to thank Dr. Dilip, the National President IMA, Dr. Anil, And my presentation that I'm going to deliver has become very easy by the words that was given by Dr. Asokon, because I was panicking that whether my public health presentation would be palatable or digestible by the IMA doctors. But now I know that the doctors joined here are not only physicians, but they are public health physicians, and they will understand the public health interventions for malaria on top of diagnosis and treatment. So I'll just close my video with this, and I'll try to share my slide. Just give me some moment, please.
Yes, sir. Slides are visible.
Okay. Just 1 second, please. Yeah. So thank you for giving this topic, which is very pertinent, because when we are talking about malaria elimination, then definitely the end game will start from burden reduction and harnessing innovation to reduce malaria burden. There are definitely strategies that are coming from the WHO side, and there are also country-specific strategies that countries have developed. So I will share some of the WHO recommendations that are already there for burden reduction. And I have made this presentation very simple in terms of that is digestible for our IMA doctors that are relevant for them. And on top of that, I have made this more operational in a sense that the program can implement the operational strategies that I'm going to present here for burden reduction. So I think all of you might have gone through our the WHO framework for malaria elimination that was published in 2017, and this slide clearly shows that the malaria elimination in a continuum approach that clearly highlights the different transmission setting that starts with high transmission, moderate, low, very low malaria elimination, and then maintaining zero malaria. And on the right side, it clearly outlines three important strategy of the global technical malaria technical strategy. And in the middle, you see these are the set of interventions which are bundled together that are relevant for suitable intervention. So I have given a box here that highlights only high and moderate transmission setting. And there are related interventions, relevant interventions for those if you really want to reduce the burden. The first is the bundle of component A that talks about the universal coverage of services. So when we talk about services for malaria, then it's definitely the case management, which starts with testing, treating, and then follow-up of the patient. And then the other component of the major intervention is the entomology and vector control, which is in universal coverage of bed nets through bed nets and the indoor residual spray. And if you see at the component B, which is the surveillance, and basically, in a high burden setting or even in the elimination, it should be increased. The sensitivity and specificity of the surveillance should be enhanced, so that every case that is in the community, that is in the hands of public health physicians or clinicians, need to be detected, characterized, and monitored. And the component C is basically an accelerator that is a population-wide approaches. So you might know that the mass drug administration for lymphatic filariasis. So similar approach is there for malaria also that can reduce burden. Then moving forward, so how to implement this bundle of packages to reduce the malaria burden. So I have grouped those interventions into two types. One is intensification of the routine activities, and the second is acceleration of the malaria activities. When we talk about intensification of routine activities, means that routine activities, what we do is diagnosis, treatment, follow-up, distribution of bed nets, and then doing IRS, and then reporting the malaria cases. But we need to intensify these basic interventions when we talk about burden reduction. And I have clearly outlined three operational steps that has been effective in some of the Greater Mekong sub-region countries. So first approach, when we talk about burden reduction, then we really need to know where is the burden. So in the India context, it could be district. Then if you drill down, it could be at the block level. And if you drill down the block, then there will be few sub-centers with high malaria cases. And even if you drill down below the sub-center, then there will be few villages which will be contributing significantly to the malaria burden. So basically, first step is the epidemiological analysis, so that we know that where the burden is and which are the hotspot. And after we know that, we enumerate the hotspot, then the second major step is to ensure that the full coverage of malaria service is there. And then the third step will be that the full implementation of these malaria services with greater quality. And these are basically for the intensification of the routine activities. And the other one is acceleration. So when we do this intensification, the rate of decline of malaria will not be that great. But when we do this acceleration, means that the burden of malaria that can go quickly at the lower level, and from where the elimination activities like case investigation, foci investigation, response can happen. So this is basically about the mass drug administration and targeted drug administration for malaria. Now I would like to take these intensification and acceleration activities step by step. So first step, as I mentioned, is this is the epidemiological analysis, and through microstratification, identifying the hotspot. Basically, hotspot are the areas. These are circumscribed areas with the malaria problem, which could be persistent also. And for easiness, the area of implementation for hotspot should be small enough so that there are enough resources, enough human resources, as well as the logistics. So for my presentation, I have used it as a village level. So for, when you talk about the hotspot as a village, then definitely we need to line list the case by villages. The cases here could be PF plus mix or PV. And then we need to use the composite indicators to basically define this hotspot. So I'll also have one example in the upcoming slides. And this could, composite indicators could be generated by by using all cases, PF alone or PF plus mix, using PV, and using other indicators like annual parasite incidence, total positivity rate, and then the annual blood examination rate. And after we use this, then we come up with the hotspot, and definitely we need to move further. So this is just an example from a country, Myanmar, where a similar strategies were applied. The intensification were applied, and hotspots were identified using these composite indicators. If you can see at the top row of this table, they have enumerated the population and then the test, PF, PB, mixed cases, PF plus mix, and total positive, and API, TPR. But they have used only three criteria to identify the hotspot village. So PF plus mixed cases more than 200, and total cases more than 1,000, and annual parasite incidence more than 10. And with this, if the village meets all these criteria, then they were identified as the hotspot. Because these are resource intensive procedures where we need human resource in place, where we need all logistics, where we need to have an intensive supervision monitoring plan, coordination efforts, so on and so forth. And when we are implementing such strategies, we cannot apply everywhere. We cannot move on towards the blanket approach. That's why this hotspot where we can implement this is very important. And the epidemiological analysis is only complete when we have 100% inclusiveness. So this is what I want to tell is, in most of the countries, the data is reported from the public health facilities. But in addition to the public health facilities, the cases are also being seen by the private hospitals or private medical colleges or private doctors that are operating in a standalone clinic. So, when we do this hotspot analysis, the basic criteria is that all cases coming reported in that village, either it be a rural healthcare practitioners or the the faith-based organizations working there, or even doctors operating in and around the villages, so that those kind of cases need to be compiled together for this analysis. And I'm sure that our colleagues here who are public health physicians have been regularly reporting those cases that come to them to the public health system. And another important thing is, for this analysis, the zero reporting with adequate ABR is very important for the hotspot. And the second step is, once we identify the hotspot using certain criteria, then we need to see whether the resources are enough there or not, the human resource and logistics. So basically, step 2 is all about the coverage. So I have already identified village as hotspot. So in a village, we have ASA worker. So ASA worker need to be there if we need to use ASA for these approaches. And if ASA worker is not there, then ASA worker can be identified. That is one option. And second option is if ASA worker is not there, and I have learned that in the Global Fund project in high burden villages, there is a provision to hire a volunteer, the village volunteer. So village volunteer can be hired and trained. And on top of that, the healthcare facility catering to this village, which is the sub-center, then sub-center need to have a healthcare worker. The sub-center need to have all kind of resources, including the treatment and diagnosis, and also the bed nets and for the top-up activities. And when we have this, then in the village, and we also know when the village is a high burden, definitely some of the malaria transmission in and around the village is also fueled by nearby activities like forest related activities, forest farms, plantation sites, coconut plantation, so many activities are ongoing nearby forest where the transmission is happening. So we also need to consider that to provide services to these work sites. So for this, a volunteer can be identified in a village and then asked to perform outreach activity in that manner. And secondly, even the worksite volunteer can be identified so that the person stays in the farms and provide the service. So if you see, the step 2 is basically ensuring that there are adequate human resources in the village, in the hotspot, or in the healthcare facility to be catered. And then the third step, as I mentioned, is the full implementation of the the universal coverage of services, and then the full implementation with the good quality. And first, as I mentioned, the case management service is important through the healthcare worker or through the ASA worker or through the volunteer that has been recruited. And they need to do routine passive case detection in this in village or in the healthcare facility. And there are also added intervention in the village that the targeted screening and treatment can be done 3 times in a year. That is exactly before the season, during the malaria season, which is the rainy season, and after the season. And fourth, targeted screening and treatment can be added during the peak malaria season as well through the house-to-house visit. And on top of that, I also already mentioned that if there are forest farms and village volunteer is staying in a village, then he or she need to go to the forest farms to provide this proactive active case detection. And the second intervention that is important is the bed net distribution. So when we talk about the village high burden, which needs this bed net, then bed net need to be distributed to all the villages if the campaign hasn't happened. But if the mass campaign has happened, then we need to do a census of the bed nets and need to be topped up to the villages who doesn't have the bed nets, because we know that in the village situation they might not use it, they might lost it, or they might get torn, or they might be using for something else. Then the top up of the LL line would be very important. And when the LL line is not distributed, then another option is the insecticide residual spray. And during outbreak, this IRS can be complemented with the bed net. And other interventions which are equally important, as I remember, Dr. Ashokan mentioned that this awareness, awareness raising is important, that villagers need to know their problem. So if they know about malaria, then they will only seek treatment, diagnosis and treatment. So they need to know the malaria. So IEC BCC activities this community mobilizations, is important in that area. And other dimension that adds quality to this coverage, either increasing the coverage or either maintaining the quality is, supervision and monitoring. And usually the healthcare staff need to monitor this ASA worker or the village volunteers that is placed in a village. And if you if in this high burden village, if you only implement the activities and do not conduct the epidemiological review and do not conduct the activity review of the ASA, of the volunteers or the healthcare worker by the healthcare facility above, then it is not going to happen. That's why a monthly meeting needs to be planned with the block medical officer, healthcare workers, ASA workers or volunteers, and quarterly meeting need to happen at the district or state level. I have seen in countries that they are, if they are very keen in reducing the burden, they organize weekly meeting to review the situation and progress. So I have this slide basically targeting on the case management, and I thought that this would be relevant for our IMA doctors. So basically, when we talk about the high and moderate settings and want to reduce the burden, then all our public health physicians who are attending febrile patients, they need to have a high level of suspicion of malaria. They need to know the suspected case definition for malaria. So suspected case definition for malaria is fever, patient with fever or with pallor, or pregnant woman, or people visiting from endemic areas. So there are the definition is wide, and they need to be subjected for testing. And testing, as per WHO, even for elimination, is RDT and microscopy is sufficient, and we don't need to go for the molecular diagnostics. And once they are diagnosed, then the physician need to provide a full course of treatment. That is important. And on top of that treatment, the radical cure, the primaquine, which is a single dose for Plasmodium falciparum, and 14 days course for the Plasmodium vivax oval needs to be prescribed, and this course need to be the course need to be completed. Otherwise there will be a lot of relapse cases in the during September and October. That's why if you analyze a seasonal trend with the Plasmodium vivax, there is always a second peak that that is a proxy indicator that this primaquine adherence is not in the not there. And I suggest, I urge our the medical fraternity, when you treat malaria patient, then we need to use the National Malaria Treatment Guideline. And this guideline is evidence-based, because this, the recommendation coming there, or the, the treatment that has been chosen is guided by the therapeutic efficacy studies. And I have given one example here that was implemented in Myanmar. I was based in that country a year ago, and then by implementing the intensification plan here in 6 states and region in 20 townships. And that represented 82% of the malaria cases in a country. And by just doing a situation analysis and planning and intensification of the case detection in the approach that I have mentioned, and bed net distribution and top-up procedures, and rigorous supervision monitoring, and you can see the results here that the total malaria cases that were 46,000 before reduced to 28,000. That was reduction was by 39%. And in terms of Plasmodium falciparum, the case reduced by 70% in a matter of 9 months. And for PV, the case reduced by 19%. And the case reduction on PV could not happen that much, because if you see at the tip of the map, at the bottom of the map, those areas had the PV outbreak at the same time when we implemented the this intensification plan. Now I would like to move to the another intervention which is promising, which is already recommended by WHO, and some of the countries in the globe are already implementing this for the burden reduction. Basically, this is an accelerator, which is the component C of population-wide parasite clearance. As you know that in a high burden settings, there will be high the population immunity. Means that the people will be infected, but they will harbor parasite, and they will be detected by RDT, they will be detected by microscopy, but they will not have any symptoms. And simultaneously, there will be febrile patients. So febrile patients will be detected, but the asymptomatic reservoir will continuously become overt malaria or continuously, transmit, continuously infect the mosquito, and from mosquito the chain of transmission is maintained. So this mass drug administration and targeted drug administration is a solution, could be a solution for those asymptomatic reservoir, which will wipe it up. And we also have, WHO also has this intermittent preventive therapy, but intermittent preventive therapy only for Plasmodium falciparum is not a WHO strategy, but countries have used this chemo prevention for forest goers. Like if someone is visiting, a forest for more than a month or for longer time, then he cannot come back and access services or forest farms, or or there is a forest occupation going on. Then the high risk group can be given ACT, full course of ACT every month. So that has been also practiced in countries. So if country is keen in implementing this mass drug administration, targeted drug administration, and then the intermittent preventive therapy, then we need thorough training for those healthcare workers and the supporting arms in the community, and thorough community engagement and social mobilization need to happen in a village, because people will not accept drugs without having a disease. So awareness at the community need to be there. Even the leaders of the village need to be thoroughly explained, otherwise they will refuse this kind of interventions. And a census should need to happen, enumerating all individuals in a village, and then implementing these two interventions. And after these interventions, then one added intervention is also needed, because some of the people will not be in the village. 100% coverage might not be there, and then the active house to house fever screening will take care of those remaining people who doesn't receive this mass treatment. But to have this intervention, there is a condition proposed by WHO that the package of interventions, the diagnosis, treatment, then bed nets, coverage, and surveillance should be up to the standard. Then only we can go with this intervention. And just to add this, MDA and targeted drug administration is a short-lived intervention, and there might be a rebound effect from this. That is why routine malaria intervention need to be in place. So I have just borrowed a slide from Cambodia program that had implemented this intensification and acceleration plan together. If you see the number of cases reported in 2017 and 2018, up to 5,000 per month cases were reported. And the intervention started in the month of October, November in 2018. So after the implementation of these rigorous interventions, then you can see how the cases declined in 2019 and then were maintained in 2020, 21, 22. And now I can say that Cambodia is very near to malaria elimination. And if our colleagues might be aware of the resistance, so this Cambodia was considered as a hotspot for anti-malarial resistance, whether it be chloroquine, whether it be the ACT. But now, with the malaria elimination approach, using these strategies, now even with the drug resistance, they are able to go closer to the malaria elimination. So in a summary, I think this intensification plan and acceleration strategies are very useful. These are already demonstrated and documented, the interventions that have been done in countries in Greater Mekong sub-region, and even in the Southeast Asian countries like Myanmar and Thailand. And and I see that this has a greater role to play when we are talking about burden reduction in India. So I would like to stop my talk here and hand it over to the moderators. Thank you so much.
Yeah, thank you, sir. I think this was a overall view is very much helpful for us, and I think WHO will continue to support by providing strategic guidance and surveillance supports throughout the integrated disease surveillance program, along with facilitation on partnership across the sectors. And I think with a special partnership with IMA, our reach will increase for the malaria program. So thank you, sir, for your kind presentation. And moving forward, we must also align the World Malaria Day theme with this. And to speak more about, I think in 2023, the reported case and deaths have declined by 80%, and 78% of deaths have been reduced since 2015. I think India has officially uh, exited from the high burden and now in the high impact group in 2024. So these achievements underscores that India's unwavering commitment and vision to become malaria free by 2030. And I think we have with us the director of National Center for Vector-Borne Disease Control Program, the most dynamic director, Dr. Tanu Jain Madam, who has taken a lot of steps and momentum to make this happen over the years. And currently, she is prioritizing on all the efforts so that we receive and we achieve that goal. So welcome you, ma'am, for your topic. And I think ma'am will be enlightening us with the National Malaria Program in India, the current priorities and strategies. So over to you, ma'am.
Thank you, Pritam. Am I audible?
Yes, ma'am.
Okay. So, first and foremost, I want to thank IMA for organizing this excellent webinar. And so the office bearers of IMA, I could catch up a lot of, initial inaugural agendas that you discussed, and there seems to be a lot of momentum happening in IMA. I've been very fortunate to meet a few of the office bearers, sometimes in the Directorate General of Health Services. So this is actually a very good opportunity when Pritam reached out to me, and today being 25th of April and World Malaria Day, it was a very heavy day, but I wanted to reach out to my fellow doctors. And my actually, I don't like taking such kind of webinars because I really don't know who my audience are, whether they are listening to me or not. So I would really appreciate if our young doctors, if they are listening and they are not much worried about their attendance and their certificates, which is the number of chats I am seeing, then you can probably pose a lot of questions to us. And I think Dr. Badri Thapa took you through a lot of public health aspects of malaria, which WHO recommends. So I will be actually deliberating more on the National Malaria Control Program and what we are doing in our country and what support we want from the IMA and especially from the young doctors. So I'll just start with saying this, that malaria is a very, very historic and old disease, and it has a tendency to come back while we turn our faces away from it. And this is what I've been observing in field and in the clinical arena also. There are a lot of things which IMA and the young doctors can help us achieve. So can we go to the next slide, or can I change the slide myself? You'll have to change. Okay. So this is National Center for Vector-Borne Diseases Control, which formulates the policies, guidelines, and provides technical financial assistance under the National Health Mission norms for prevention and control of 6 vector-borne diseases. These vector-borne diseases, we are all aware, are seasonal and outbreak prone, so very difficult to control and eliminate. And currently, the 3 parasitic diseases are under elimination, which is Kala-Azar. You are all aware of it. It's visceral leishmaniasis, lymphatic filariasis, and malaria. So most of our young doctors have really forgotten that lymphatic filariasis and Kala-Azar still exist in the country. So it is just a gentle nudge and reminder that kindly keep your eyes and ears open, because what the mind doesn't know, eyes never see. And since we are sitting in the ministry and mostly doing the policy work, of course, we do go to the field quite often, and we are in the villages, we meet with the district hospital officials, we go to medical colleges, but you are seeing patients on a daily basis. So my request to you is that kindly be aware that these diseases are still lurking around, and these are vector-borne diseases. Vectors are there, so we have to be very cautious. I don't need to tell you the vector, you are all very learned. Looking at this map, you can see what Dr. Pritam was saying and what the other office bearer was saying, that now we don't see malaria that much. This map looks very reassuring and looked rather more reassuring in the last year, because Odisha was not red, Odisha was yellow. But now at the program, we have started intensifying the case search to, ensure that each and every case in the community is identified, reported, treated and tracked. So that is our current policy. And because we have onboarded our IHIP near real time data, and now we are getting more and more reporting. So as you can see now, Tripura, Mizoram and Odisha continue to be in category 3, which is a very high burden category. It means that the API is more than one, not only in the state, but in all the districts of the state. And this is a major cause of concern to us, because India is not states are not watertight or waterbound, states. They are all lot of migration happening either, and then tourism happening. So this is a acute disease. Vector is available everywhere. So we are having a risk of resurgence in the areas which have gotten free from this. As you can see in the category 0, that there are 4 states: Sikkim, Lakshadweep, Ladakh and Puducherry. They do keep on getting cases, but when we do a case based investigation, we find that they are mostly not indigenous cases, but they are cases, migrated cases or tourists coming for tourism. So let's move to the next slide. As you can see, this is a very important parameter for us. I think Dr. Badri also showed that these are the parameters which actually help us identify the hotspots, and we come to know where we need to increase our surveillance, where we need to increase our activities. So now you can see that post-COVID, we had a good, dip in the annual parasite incidence, but the annual parasite incidence has shown a slight rise in the last 2 years. But it is also complemented by a rise in the surveillance which is happening across the country. And not only the surveillance has increased, but also the reporting from the various labs has also increased. We have been intensifying these efforts. Can we go to the next slide, please? I'm sorry, Dr. Preetham, I should have shared the slides. Next, please. Can we go ahead? Yeah. So, so that map was very reassuring, and then we actually delved down, as Dr. Badri was saying, that every country needs to really look into where the problem lies. So there are currently these 37 districts where the API is very, very high, and we are now focusing. And today itself, in our National Center for Vector-Borne Diseases Control, all these states and districts were there. So we had invited the district medical officers and the block medical officers, who are the young medical officers who are posted at the block. And I find that they are the ones who are responsible majorly for ensuring the treatment of malaria, but they are the ones who are least informed, because now in the public health arena, the program has shifted to ASHAs, to ANMs. So everybody seems to be reaching out to ASHA, who has become like a multi-purpose worker. Nobody bothers about what the medical officer is doing. So we are reaching out to medical officers in all our programs, and we are requesting support from the medical officers, from the private hospitals, to kindly help us identify these cases and ensure their treatment. So this is the deep dive into seeing that how within the states the districts are, and within the districts again we have selected the high burden blocks where the specific action plans will be implemented. Moving on ahead. So this is very important, because this is the National Strategic Plan we just launched on 2nd January 2024. And this plan, the formation of this plan is from 23 to 27. And this actually outlines the strategies which the country is trying to adopt. Moving ahead, please. Can we look at the strategies? I'll take you very briefly through the strategies, because most of the strategies Dr. Badri has told. So we are having a vision of malaria-free India. The world is looking at India. They're just waiting whether we'll be able to do it or not. And we are really, really geared up, and we really need all the support from each and every one of you. So malaria elimination is aligned with the Global Technical Strategy of 2016 to 30 and National Framework for Malaria Elimination. And we need to interrupt local transmission. That means zero indigenous cases. So it isn't going to be a very easy task. It is going to be a very challenging task, because zero indigenous cases means today we are having 255,000 cases. And in 2 years' time, 3 years' time, we need to reach down to zero. So if you calculate it mathematically, it may look impossible. But if we really put in our efforts, at least I don't believe in impossible things. There is everything which is possible. If we put in our efforts and we are doing our best at the national level, so definitely we will be able to achieve this target. Next, please. So as I already told you, I think last time when I met the IMA office bearers, there was an issue of lack of a reliable website where they can enter their data. Now that website is available, the APIs have been shared with the states, and mostly the states are sharing the APIs and the credentials of login credentials with the labs and the big hospitals. So if you want to be a part of it, and if you are in a state where high number of cases are being reported in the private sector, you may kindly reach out to your state program officers, your district program officers to help you enter this data on this IHIP portal. The more data that we enter, the better, we will be able to control our disease. So 26 states have shifted to paperless monitoring. We are waiting for the next 10 states. Go ahead, please. So this is the most critical strategy for us: testing, treating, and tracking. And we are all aware, we are doing RDTs, we are doing slides. But what I have actually seen in my practical experiences, that even in medical colleges, even in places where there are labs, people are doing RDT and not making the slides. So if you're not making the slides, not only you are missing out on the general hematological condition, but you are also missing out on the species identification and the skills that are required. So we kindly, if you are in a bigger hospital where there are labs and lab technicians, then please make slides as far as possible and give the result as quickly as possible. And most of the time RDTs are for peripheral workers who are in the field and then in the hard to reach areas, so they have to go and do the testing and give the treatment, start the treatment immediately. So these are some of the high burden areas where the ASHAs and the field level workers are doing the RDT test. Next, please. So then we are doing entomological surveillance. Vector has been talked about previously also. So I think one of the most important thing is to keep our surroundings clean. Ensure that there is no stagnant water sites, dirty stagnant water sites around us, so that vector breeding can be minimized. And I think IMA can also issue some kind of advisories saying that this is a night biting mosquito, so you should wear full clothes while sleeping. Try to sleep inside a bed net, because insecticide treated bed net, which is LLIN, is not available in the market. It is a program strategy in very high burden areas, because as we have resistance to drugs, the vectors develop resistance to insecticides. So therefore, we cannot really make it open market. But we have a strategy wherein all sub-centers with more than one API are given the LLIN. It is provided free of cost to the country. Next, please. So these are some of the efforts that we want to accelerate. So we are having very, very high level meetings with the chief ministers of various states, with the very high senior officers, and we are getting a lot of stewardship from our Honorable PM. As was told that on in December 2024, Honorable PM appreciated the efforts made by the program, and Honorable HFM reviews from time to time. And so we are doing a lot of advocacy and social behavioral change communication. So right from the grassroots level to the community, to the patients, to the healthcare providers, to the traditional healers, which make a major part of our chunk of our healers in the field where the others are not there. So I think I'm getting good questions from someone. Most of the laboratories are run by DMLTs, so they prefer RDT. So I think we are training. I will be actually telling you that we have a national reference lab where we are conducting the trainings, and these trainings are being conducted although for the state lab technicians. But if you recommend to us, we will try and undertake at least 1 or 2 batches if the IMA recommends some lab technicians to be trained for malaria microscopy. Can we go to the next slide, please? So these are the research studies that we are doing with NIMR, National Institute of Malaria Research, and Vector Control Research Center, VCRC Puducherry, which are under ICMR. So we have just started under the Global Fund grant, therapeutic efficacy studies, household surveys to understand in depth the epidemiology of the malaria, insecticide resistance studies, and then to look into the various malaria paradigms. We will be coming out with the results within a year time. Next, please. Next, please. Next. So I think everyone has already told that we've had almost 80% reduction in cases, 80% reduction in death. API has reduced, and good news is that approximately 103 districts are reporting zero malaria cases, and more than 150 districts are reporting zero malaria cases in the last 1 year. So this is a very important step that has happened. But again, it's a very porous border with the states, so migration and all can actually reintroduce the cases in the areas where the zero cases have been achieved. Next, please. So just moving on to, as Dr. Badri said, that everybody should be looking into the government policy and the national clinical guidelines for malaria treatment. So all suspect malaria cases should have parasitological test through microscopy or RDT, and we don't need the molecular test for that. This already has been discussed. Next, please. So this is the gold standard, still remains the thick blood smear and the thin blood smear. So I'm assuming that we have pathologist and microbiologist also with us. So kindly encourage in your labs to make these smears and try to detect more and more cases through that. Next, please. Next. Yeah. So this is the RDT. Please, can we go ahead? I think we've already discussed, and you are all clinicians. I'm sure you know better than me. So please go ahead. So just briefly, we'll be taking you through the national guidelines. The PVIVAX guidelines are chloroquine 25 milligram per kg body weight into 3 days, and primaquine, which is 0.25 milligram per kg body weight daily for 14 days. Now, the challenge that we are facing in PVIVAX is the treatment completion, and this is a huge challenge. And mind you, I have already noted that so many times when I visit the PHCs or CHCs or even district hospitals or private medical colleges or private practitioners, I ask them that, are you prescribing full 14 days treatment? So many of them are not. And many of them are not asking the patient to report back to them after 14 days. So I know that it is not possible that 100% people will comply to your directions, but at least that percentage will increase from maybe 20 to 30% currently to maybe more than 80 to 90% in times to come. So may kindly ensure that this 14 days treatment is prescribed and followed through and regularly. So as we all know that ACTSP was found to be resistant in some of the therapeutic efficacy studies, so we have discontinued in the Northeast. We are giving ACT-AL now. Next, please. Next, please. Yeah. So again, this is a dosage chart, and I'm sure you are all available. You are all having a knowledge of this dosage chart. So if you want, you can go to our website, and all these details are available on our website as well. And we keep on sharing with all the states continuously. Next, please. And I also want to give you one very good news that point of care G6PD test is being tested, and ICMR is finished doing a study on that operational feasibility of this. And if the point of care test is introduced, it will be a big game changer even in the field, because in the field many a times, although we do not have a high percentage of G6PD deficiency, but still people are very scared. The peripheral health workers, the new block medical officer is very scared to give primaquine because they're scared that there will be hemolysis or they will land up in trouble. But now, if we are able to launch this point of care G6PD test, it will be very helpful in the peripheral villages and states. Yeah, please go ahead. So again, this is the treatment schedule for the severe malaria cases. I am not going to go into the details. You are all aware of it, but you can take note of it, and you can also go to our website to check the details of it. Next, please. We have already talked about this slide. Honorable PM mentioned about malaria success in his Mann Ki Baat. National Reference Lab was inaugurated by Honorable HFM on 2022. High-level political commitment is there, and India has exited from the high burden to high impact countries in the World Malaria Report. And we have global fund funding of about approximately $65 million. We are through that funding utilizing it to strengthen IHIP, providing support through non-government organization, which are state SRs in 7 endemic states, to strengthen surveillance, treatment completion, IEC, BCC, and capacity building. Next, please move on. This is the launch of the training module that was done by Honorable DGHS today, and our, DGHS, as you know, will now be relinquishing this office, and Dr. Sunita Sharma will be joining us as DGHS from Monday onwards. So she had also graced that occasion. And for the 103 districts which have achieved the zero cases, we have prepared sub-national malaria verification guidelines, and these guidelines will be tested, and then we will see, because 10 years data will be required by WHO. Dr. Thapa otherwise will not give us the certification. And then district action plans are being formulated as we speak today, and I have already talked about the IHIP and ASHA training. Yes, of course, somebody has asked for the PPT. So Dr. Preetham, can you kindly share the PPT with the participants after this? And now we have also developed a DVDMS portal for stock related monitoring. At the center, we are procuring all the drugs and diagnostics for the states, including the RDT kits, including the ACTSPs and the ACTAL, LLIN. So we are procuring everything, and this is distributed right up to the village level. So for that, we are actually now onboarding on DVDMS portal so that we can do. And one thing which I also want to emphasize is, kindly, when you are sitting in your hospitals, especially in the government setup, please check your pharmacy. None of the drugs should expire. I think as physicians, it is our great responsibility to ensure that the expiry is not there. What happens, that number of cases go down, nobody looks at the expired drugs, and it is very, very painful when I go to the field and I go to a pharmacy and see so many drugs are lying expired. It is, and biomedical waste management, write-off of expired drugs is a huge challenge for us. So ultimately, what happens, the peripheral workers, out of fear, they just bury the drug in the soil. So you can just imagine that how much we are polluting our environment by our just not considering that as physicians what all we can do. So kindly ensure treatment completion, kindly ensure that none of the drugs expire in the field. Next, please. Yeah, I think this is repeated. Please go ahead. And this is the National Reference Lab, and you are most welcome to visit us at National Center for Vector-Borne Diseases Control. Go back. So this National Reference Lab also looks after, just go back, Pritam, also is training all across the country, the L1 certified trainers. That is the WHO certified trainers. Just go back one slide. Pritam, just go back. Yeah. So you can just see that we have a pool of L1 certified trainers, and these trainers can actually become global trainers as well. And we are now moving on to malaria microscopy initiated quality assurance in the states with the help of 17 regional offices of health and family welfare, which also I am looking after at the national level. So these are the various things that we have been doing for the last 3 years since the time our Honorable Minister inaugurated this. And all 17 regional offices are also now center of excellence in the country for training into malaria microscopy and filaria microscopy. Can we go ahead, please? This is the Ayushman Arogya Mandir which are coming up, and the whole malaria package and VBD package is delivered to the 12 communicable disease package in the Ayushman Arogya Mandir. And you can have a look at the IC that we are showing in these Ayushman Arogya Mandir, and we stock these sub-centers. They are basically the upgraded sub-centers with all the medicines, the LLIs. So they are the nucleus for us of the program. Please go ahead. So I think I have mostly covered all these things, but the challenges still remain. 37 districts are contributing to 70% of the cases and more than 50% of the deaths. So that is why these districts are sitting in the national center, and tomorrow also they will be sitting and they will be making the presentations on their district action plan. Treatment compliance is a huge challenge. I request you all once again, I think I've been requesting after every 4 sentences. So please kindly help us ensure treatment completion in periphery. Engagement of informal healthcare providers. So most of the time what happens is that the traditional healers and others, they delay the patient for too long, and therefore the transmission goes on, the patient becomes serious, and we have a lot of fallbacks in this. Lack of involvement of private practitioners in malaria, that is our fault, but we are trying to overcome that, and we'll be happy to involve with you as much as possible. Then malaria in tribal population, forest, urban, it's so many paradigms, such a complex disease, such a simple acute disease, but such complex paradigms, very difficult to really eliminate. So we will need all the help. And majority of deaths which were reported to us in the last few years, that is more than 5 from Maharashtra, Chhattisgarh, Odisha, and Assam, and low annual blood examination rate in Bihar, Delhi, Jammu Kashmir, Ladakh. So if the blood examination rate is not good, then we don't know for sure that we are not missing out on cases. We expect 7 to 10% of the population to have fever in a year. So that should be the ABER at least in a state. Next, please. Next, please. I think we've done that. This we have done. I am not going to repeat this. So these are the challenges and what are the steps we are taking. I think I have done everything. I'll be trying to share these slides with you. I'll be happy to take some questions, and we'll be doing therapeutic efficacy study to see whether the drugs are still sensitive. The vector is parasite is still sensitive to the drugs, and we'll be handing out the reports by the next year. Next, please. Okay, I want to thank all the health workers at the grassroots level for implementation of VBD control activities. But I also want to thank my friends, and because I just want to mention here that I belong to a family of clinicians. I've taken public health, but I do belong to a family of clinicians. My father was a state IMA president. So I feel very happy to join you all, and I look forward to support from you. Thank you very much, everyone.
Thank you so much, madam. So it's actually an enlightening presentation from you and also Dr. Thapa. And what we expect that what we offer from IMS side, that IMA has numerous branches in every district. And if I consider the high burden districts and all the IMA branches of these high burden districts, if with the help of the government of India and from your department, we can train all the physicians, all the IMA members, so that I think that the discrepancies regarding the treatment part of the private by the private practitioners, that can be lowered down. So this is my suggestion to both the leaders of IMA as well as to your team. So Dr. Pritam Rai, please.
Yeah, so you have my presentation, so you will have, I think I've shared a lot of data with you. So these are the districts that are there, but we'll be happy to organize such kind of trainings for you as well. We have some kind of, setup in the states, and we will be very happy. And in fact, for lymphatic filariasis, we have taken a lot of support from the IMA, and we did get a very resounding, support at that point of time.
Thank you, ma'am. I think that is really helpful. And I think together it's a long journey with IMA. We will be having more such sessions, more such deliberations. And ma'am also discussed about other important diseases in which in coming days, we will be also having. So we will be also discussing if anybody has any question, maybe please raise. And Dr. Anirban, we can moderate if there is any questions, and then we can take forward.
So, madam, yes, one question has come. I will take 1 to 2 only, because it will be a lengthy discussion otherwise. So first one of is antigen positivity persists for 4 weeks even after complete treatment, or it could be up to 90 days. Please discuss. That is by Dr. Kaushik Chaudhary, is a deputy CMOH2 from Kuch Bihar district.
Yeah, that's all right. So that is why sometimes we keep on getting the positive. That's why we encourage that you do a lot of, you try and do microscopy, because that still remains a gold standard for the treatment. So that we do consider while we are doing, to take a past history of malaria.
Yes, thank you, ma'am. And another question, where can patients find the readily available blister packs of malaria treatment? As he is mentioning that we treat patients in private practice, as most practice of medical shops don't keep the blister pack. So I think it will be from the government's of healthcare delivery system only. Madam,
Yeah,
please.
mostly we are giving these blister packs, free of cost. And I can actually share some of the pictures of the blister packs that we are providing to the states. And maybe if you are, residing somewhere near a district hospital or a PHC, CHC, you can have a look at that. But I think the pharmacies are also having those blister packs. I have seen that. So these packs are available.
And another one, where do private practitioners report malaria or other vector-borne diseases to the government system? Is there any portal for the private practitioners?
Yes, so I have shown you the integrated health information portal, and many private labs and private practitioners are already entering. We are getting data. So mostly your state will give you the credentials. So we will write again to the states, we will copy it to the IMA branch, and maybe we'll copy it to the state branches of IMA. Pritam, you should help us out with this. And once we do that, then you will be able to enter the data, because there was an issue like till last year we did not have a portal. So we could not really, tell you where to enter the portal. And this is a very friendly portal. And on that portal, you can also see the national data and all the information we have put there as well. So all these information is available on the portal as well.
I think this is a
Okay,
very
ma'am, thank you. And
pertinent
last
point,
but
which
yes,
Madam told. So, along with the IMA, so we have their inputs, and together
and
we
one
will
more,
have
Pritam
a
sir.
subsequent session also for this, for taking up
Yes,
these
yes.
points also. So, how we can
With the
collaborate and coordinate and deliver this.
under the guidance of our national president and the national leaders, we can have this at district level and the branch level also. And another question, like it is question for all. I want to ask Dr. Thapa if he is there. So what's the efficacy, or what's the idea about the vaccine against the malaria? Dr. Thapa is here.
Yeah,
Yes.
thank you, Anirban. So I'm still here. I'm listening to the conversation. So WHO has approved pre-qualified two vaccines that are primarily for the Africa setting, no? And their targets the children less than 5 years, and where the transmission is actively ongoing in the children, no? And where a lot of children are actually dying. So the vaccine is targeted basically for the children. So it is not relevant for India so far.
Thank you. Dr. Rai, please.
I think there are a lot of things. So as we move forward, I think what ma'am said that the IMA leadership in the beginning, we saw enthusiasm, and also there so we can have a round of talks and coordination with the IMA and the national level, and formulate so that we can jointly move forward together, have national level priorities set in, sharing the details, and then we move to the state and the district level along with things. So I think this is a
Thank you
very
so much.
good start
So
for
we
the
are
vector-borne disease with the jointly with IMA and NCDC. And in coming days, we will have more such sessions and coordination meetings.
yes. So with this note, I would like to go to the national leaders of GDN, Dr. Garima and Dr. Sudhi. I hope they are here. So I request her to take forward this note and then conclude by Dr. Urvesh Shah, please.
Thank you so much, sir. Good evening, everyone. I would like to thank. Am I audible?
Yes, Garima, you are audible. Yeah.
Thank you so much. I would like to thank everyone, all our senior leaders, Dr. Dilip Bhanushali sir, Dr. Anil Naik sir, Ashokan sir, Sarbari ma'am, Lele sir, Utture sir, Srijit sir, Indranil sir, Anirban sir, Karan sir, and all my colleagues for this opportunity. Regarding now, we will be talking about young doctors' role in malaria prevention and reporting. Young doctors play a vital role in fight against malaria through both clinical practice and community engagement. As frontline healthcare providers, they are often the first to diagnose and treat malaria, especially in endemic regions. Their responsibility extends beyond treatment to include educating people on preventing measures such as the use of insecticide-treated nets, indoor residual sprays, and the importance of early diagnosis. Additionally, young doctors contribute to robust disease surveillance by accurately reporting cases to public health authorities. Their vigilance ensures timely detection of outbreak and help shape effective responses. With fresh training and a strong sense of social responsibility, young doctors are well positioned to advocate for research, influence policies, and drive awareness campaigns within their community and peer groups. By combining medical knowledge with proactive outreach and reporting, young doctors become key players in the global mission to eliminate malaria. I would like to share one of my experience which we, along with the MSN and JDN, have conducted in Dharavi in the past under the banner of JDN to educate local people about malaria and preventable measures. These campaigns can also be conducted by all others as well to spread awareness. Thank you so much. I would like to hand it over to Dr. Sruti. Thank you.
Thank you, Karima. Good evening, everyone. Am I audible?
Yes, you are audible.
A very good evening to all the IME dignitaries, office bearers, and one and all present here. My heartfelt gratitude for the opportunity given. Today, I want to highlight the crucial role young doctors play in malaria prevention and reporting in India. As the nation continues its fight against malaria, we young healthcare professionals stand on the front lines not just as caregivers but as change makers. Firstly, early diagnosis and timely treatment are essential in controlling malaria. Young doctors, with their updated medical knowledge and energy, can ensure accurate diagnosis using rapid kits and proper case management, and especially in rural and high risk areas. Secondly, we must actively educate communities. Many people still lack awareness about mosquito breeding, symptoms of malaria, or when to seek help. By conducting awareness drives, school sessions, and local health camps, we can promote the use of mosquito nets, repellents, and environmental cleanliness. As of Tamil Nadu JDN team, we are planning for each district a particular camp for malaria, especially for malaria awareness for the month of June. Thirdly, reporting and surveillance are critical. Young doctors must ensure all cases are reported promptly to the local health authorities and integrated into the national malaria surveillance system. Accurate data helps in identifying hotspots and allocating resources efficiently. Lastly, we must advocate for policy implementation and innovation, supporting government programs and embracing digital health tools for tracking cases. In conclusion, the role of young doctors is not just in treating malaria but in preventing it, reporting it, and educating against it. Together with dedication and action, we can help India move closer to a malaria free future. Thank you so much.
Thank you so much. I think now we have to have the concluding remarks from Dr. Umesh Shah. And I must again be thankful to Karan and Indranil for their overwhelming support throughout the whole session and before planning it. So thanks, dear.
Yes, thank you very much, Dr. Arinbar. And rightly said, yes, this is a wonderful event. And apart from that, I must say, so many wonderful events and the fruitful events been done. Even still, we have not completed the 1 month of beginning of our tenure, right? But under guidance of the Shijit sir, there are lots of the activity being done by this new team of the IMJDN. It's really marvelous things what's going on. And again, that what I have observed that every time we are going with the good protocol, very good number of the participation we can see today also there is a good number of participations. Always start with the wise advice from our leaders. This is also very important. For example, today, apart from aligning with the scientific knowledge, what we get the advice that we have to go whenever we are going for our project like Aao Gaon Chale, we can incorporate this our knowledge for increasing the awareness among the community for prevention of the malaria. So this kind of the advice will definitely also help. Okay, today about this today's session, it was really wonderful, moderated by Dr. Pritam Roy and Dr. Anirban. Dr. Badri Thapa sir said about the roadmap on the malaria elimination and burden reduction. Sir, IMA will definitely support you what you said about the 100% inclusive and the 100% reporting. Yes, Dr. Tanu Jain, Madam Director of the NCBDC, she also covered very nice about the entire topic. And as we are heading towards the elimination of this vector-borne disease, like 23 kalas, or which perhaps very much we have covered, by 27 the filariasis, and by 30 malaria. Definitely with help of the and with the support of the IMA leaders, and with the help of the IMA and all the bodies, we will get the success. Yes, testing, treating, and tracking, it's shall be our motto. We will follow that. Also stress upon the Primaquine or the SED based complete course. Definitely this knowledge will be shared to the others, and also we will insist that this thing will happen. Finally, what you said, that it really new for me, that it point of care G6PD testing may be available shortly. I think it is going to be a game changer, because nobody will now fear about giving the Primaquine if long-term Primaquine is to be given. So thank you very much, both the speakers, for this wonderful insights. And finally, the Dr. Garima and Dr. Shrudesh, you both also give very good conclusion. So overall, it's a wonderful session. Thank you very much. I am a JDN. Thank you very much, the national leaders, Srijit sir, Indranil, Dr. Karan. Thank you very much for this session. Thank you.
Thank you so much. I think we are at the verge of the conclusion of the session. I just now request Arijit from Assam, Dr. Arijit Rumu Borua, to give the vote of thanks.
Yeah, good evening, everyone. Yeah, I am here. I'm audible. Am I audible? Hello.
Yes,
am I
you are
audible?
You're audible.
Yeah, thank you. Yeah, this was actually a very, very wonderful session and a very enlightening session, for especially for people like me who come from a very endemic state of malaria. We have got still a very high amount of cases. So the elaborations that were given by both the speakers were very, very important and insightful, especially for the junior doctors, as rightly said by Dr. Suri and Dr. Garima. The junior doctors are the frontliners in giving first-hand detection and also treatment and also counseling and also making awareness about malaria. So this session by IMA-JDN is of course fruitful to everyone under the blessings and guidance of our national leadership, our IMA President Dr. Dilip Bhanusali sir, and President-elect Dr. Anil Nayak sir, Dr. Sabari Dr. Ma'am, Honorary Secretary General, and also our very own IMA-JDN Chairman Srijit sir, Anirban sir, and Indranil Karan, and everyone. I'd like to thank everyone for this insightful session. And yes, as rightly said by Uresh sir, we are into just 1 month of our session, and we have been able to do such good programs, and we'll hope that we'll continue to do this in the future as well. Thank you all. It was a very good session. Thank you all.
Thank you so much, everyone. We'll end the meeting here. Thank you, Pritam sir. Thank you, Anirban sir. Thank you, Yogesh sir.
Welcome, sir.
Thank you so much. Thank you, Indranil,
Thank you so much.
Karan, and
Thank you to
also
IMA
to
leadership
Srijit
also.
sir.
Thank you.